I'm Dr. Ken Allen, and I'm going to discuss some cases with you. My clinic is at Virginia Equine Imaging in Middleburg, Virginia, and going to go through some cases that are interesting and have some specific locomotor pathology problems. I'm the Vice President of the International Society of Equine Locomotor Pathology. It's a group that presents cases on a regular basis, so I'm giving you some examples of what you're going to see if you're a busy equine veterinarian doing sports medicine practice. In this case, it was a 10-year-old Oldenburg event horse. Competes regularly at the preliminary level, and the presenting complaint was recently started refusing, not jumping well, which is not an uncommon scenario for an active event horse. And the question is, what's going on with the change? So as we talked to the client about the history, we started suspecting that this horse might have an axial skeleton problem. Okay, so we start with a physical exam. Here you can see we have response over the back and in the area of the sacroiliac. We also have some excessive fill or joint effusion in the right front coffin joint. And when we see something like this, we get concerned that when a joint produces extra fluid, that's an abnormal joint. And so we're concerned that it's not the quality of fluid we'd like to see in that joint. So then as we moved the horse, we saw that it was lame in the right front. In our practice, we use a weighted surcingle to evaluate the back. Some of these horses, the clients don't want to ride them because they've presented with bucking. And so logically, the client doesn't want to ride those horses oftentimes. So the weighted surcingle puts weight and pressure on the back, but without the weight of a rider. This horse would very much buck when asked to canter and be upset. So then we ran through the hoof testers, the flexions, and then we have now moved on to our diagnostic blocking. So we're going to go ahead and block and see what level. So we had as you could see there on our initial, we had a 2/5 right front lameness. Then on our block, it switches, the right front blocks out and it switches to a left front lameness, slightly less than the right front initially was. Sound on the right. So we block the left front. Then it's sound and it switches back to the right. We then go a little higher, blocking the entire foot. The right front lameness resolves, the horse's sound, but again, we still are concerned about the back. So our diagnosis is axial skeleton pain and bilateral front limb lameness that blocks to both feet. So a logical thing to do there, because you have multiple areas of the body involved, is to do a bone scan. So we did a bone scan and we started immediately becoming concerned where you see the arrows are pointing on this area of the right front foot. Okay, and there's a hot spot there that is only seen in the right front. There's no corollary to it in the left. So we were concerned about that. We also see, and you can see arrows also pointing out here, both the sacroiliac area and also some in the back area here. Here you see it on the dorsal view, and here we see it on the lateral view. And then here, these arrows point out the increased uptake in the sacroiliac joint. So we radiographed the front feet, didn't see anything. So we recommended MRI of both front feet, trying to get to that mystery bone uptake that was going on, that was again negative on the radiographs. What you'll notice here on the MRI case is that there is a cystic looking structure in P3 in the central aspect of it right here, and you can see the arrow pointing to it. So I've got some additional views. Again, the arrow's pointing to it on the right front. You can see there's no lesion there in the left. And here you see this is a slightly different sequence. But again, the same thing, that white area here and a more normal kind of dark gray, almost black area on a stir sequence. So we've got a problem here in the bony aspect of the coffin bone. So ultimately what our diagnosis is, again, tough one to get to because you'd x-ray this case and see nothing. And of course that's kind of the standard for most imaging, is to block it, x-ray it. That really didn't tell us the story. What told us the story was the bone scan, which led us on to an MRI ultimately, which showed the lesion in greater detail. So we called it P3, cystic formation and edema, sacroiliac inflammation, and then bony remodeling at the dorsal articular processes of the back. So treatment of this is we injected the dorsal articular processes with cortisone, and then we ultrasound guided. Both of these are ultrasound guided techniques. We ultrasound guided the 4 approaches to the sacroiliac, 2 in the front aspect of the sacroiliac joint and 2 in the caudal aspect of the sacroiliac joint with, again, cortisone. We gave IV Tildren for the treatment of the edema and cystic formation in the bone, hoping to go ahead and get that to close up. And then we put Denois onion shoes on both front, and those are shoes with expanded heels, so they'll take more heel support, but without a crossing bar that can cause problems. So this was a pretty interesting case, hard to get to without advanced diagnostics here. And then from a rehabilitation standpoint, we'd ride walk this horse only for the next 30 days, reevaluate, and then if need be, inject the coffin joints and the navicular bursa if need be to go forward. And this horse has actually done quite well and has responded to the treatment. We have to caution the riders that this takes a while. Tildren takes a month or 2 to get firmly established in the bone, and then longer to try to stop that cystic formation. So very interesting case, a case that points out that, you know, you can be the world's best clinician, but sometimes hoof testers, nerve blocks, and x-rays are not going to be enough. And you're going to have to go on to advanced imaging to really get the answer. And that's where the answer lay in this particular case. So I'll talk to you about another case that was interesting. This was also a young event horse. And this horse presented very lame on the left front. You can see this is a 3 to 4 over 5, left front circling both directions. So a horse that we don't honestly like to trot very much because it's so lame. Yet only had moderate response flexion on the left front. Hoof testers, we did have some suspicion there. And so you always worry about, gee, could this be as simple as an abscess? And so there was some effusion in the tendon sheath. Again, the same thing. Anytime you see that excessive fluid effusion in the fetlock and the tendon sheath, you're concerned about those areas. So we blocked the foot, and the horse immediately improved with just a medial block. That's where the pulse was, the hoof tester response, and we were concerned that might be where it is. So as we blocked the entire foot, we entirely resolved the left front lameness. So we radiographed the foot, really no abnormalities. And then we were suspicious of an abscess. And you know, you want to be reasonable here and not go do an MRI if this is an abscess. That's a waste of technology and money. So we're trying to be careful with the client's money here. So we soaked and packed it for 5 days, sent it home with the client to do it. And then we said, you know, but this horse is very lame. If it's not getting better, we need to get past that abscess supposition and move on. This horse did not improve at all. And so we went ahead with an MRI. Now, This is an MRI, and you can see I've got red arrows here. I'll show you the left front along the top, and then the right front along the bottom. And of course, the left front, you remember, is our affected leg. And if you look at this navicular bone, you can see that there's very little structure in the lower half of the navicular bone, and it has this dark line across here and this large cystic structure. Where this is on the right is a much more normal looking navicular bone. We go to a separate look at it here, and again you see a large cystic structure, and you see almost the entire bone is black there, as opposed to the opposite side, which looks much more normal here. And then finally we look at this view, which has this kind of blunted black look to the bone, which is abnormal, and here much less so, and a little bit of a smaller structure. So we were very concerned about the distal part of this navicular bone. We also looked here on the left, and again the left is along the top, the right is along the bottom, and we saw some fairly significant navicular bursitis right here and right there where the arrow is. Now the bursitis is on both sides. And then we also saw that there's a lot of extra fluid in the joint capsules here in the coffin joint. So again, the coffin joint runs from this dorsal pouch through the coffin joint, and then also has a palmar pouch right back here. So this is abnormal in both these. Both the bursa and the coffin joint are abnormal. So our initial diagnosis is severe bilateral front navicular. We have fractures along the margin of the bone and cystic structures, fairly bad in the left. And then we're concerned as well about the bursitis, the coffin joint synovitis or inflammation, and then we have bilateral navicular bone edema. So the initial treatment outcome was Tildren. We did an IRAP series on both front coffin joints, and we injected both front navicular bursas with cortisone. We then did corrective shoeing, and I'll show you why we did the corrective shoeing. The client thought the shoeing was great. We had a little bit of a different opinion, and then this horse did quite well and went on for a year. And here's the shoeing before, with the heel hanging over and the shoe ending here, and here's the shoeing after. So you can see we pulled the shoe back under the toe. There's now heel support as opposed to this heel just hanging out here. And then, like I say, we've now shortened the breakover so this horse can break over much more quickly. So we're a year later now. The gelding has re-presented now for acute left front lameness, and this time severe distension of the tendon sheath, not just moderate like we had seen before. The tendon sheath was then injected with corticosteroid, and we monitored the improvement. The horse did not improve. So we're back and evaluating this case in more detail now, and the lameness is less than we had seen before, but still significant. So we block it in the tendon sheath. The horse does not improve at all. We block the left front foot, and the horse is once again sound. And then we look at the radiographs this time, and there are changes, but again, we're comparing the radiographs with the previous set as well. And you can see that there's irregular margins here along here, where the red arrow is, some enlarged synovial structures, and then some white here in this typically kind of more darker gray spongiosum, the soft part of the navicular bone. So as we ultrasounded this, because we were trying to avoid going to MRI with it again, we immediately noted that there's a defect here in the deep digital flexor, and this is about mid-pastern. And so that's visible on both these, and that was caused quite a bit concern here. Now in the end, we discussed it with the client, and they They realized this was a very serious diagnosis for this horse the second time through. They wanted to MRI it again. So we set that up to where there's actually, second time we MRI him, it's cheaper for the client. And so that encouraged them to go ahead and get this scan. What we saw was extensive cystic change, as well as even more marginal fractures than what we had seen before. A lot of synovitis and tenosynovitis, and then also bursitis. And then we see a very irregular margin where the red arrows are pointing at here along the distal aspect of the bone. So that was of concern. So our diagnosis was deep digital flexor tendonitis at the mid-pastern, tenosynovitis of the tendon sheath, and then cystic change. But you'll note that we did make the comment, really there's no interval change. So while the x-rays looked ugly, x-rays looked ugly before. So you have to evaluate the entire thing. So really what changed here is the deep digital flexor tendonitis. That was the new injury on this horse. So bursitis, edema, coffin joint, synovitis as well. So our treatment plan is we injected the lesion of the left front deep digital flexor, the medial lobe with platelet-rich plasma, PRP, and then we retreated again with Tildren to treat the navicular edema and the navicular bone. And then if we could get the horse responding favorably, then we'd go ahead and inject coffin joints in the bursa again. So, I mean, that shows you that this horse actually went on and did quite well, even though it had very ugly navicular bones. And that shows you these can be treated successfully. This horse was sound for a good year, was in full work and doing quite well, but then relapsed, but it relapsed with a completely new injury to the soft tissues. So this horse is still in its rehab process. We're hoping it will be back at the end of the year. The client's realistic that it may not be able to do everything they had hoped it would do because it's a relatively young horse. But it does show you that if you are accurate with your diagnostics and slog through all the difficult details, you can be successful in treating these horses, and then you always have to be aware that they can have a new problem. So that's some of the difficulties that we as sports medicine veterinarians face every day as we do this job. It's rewarding and fascinating to have the horses teach us something new every day as we go through the diagnostic workups. I learn something every day I treat horses. And then I think it also shows you the heart of the horse, which we'll keep trying if you'll give it a little bit of help. So that's what I have for you today. Hope you enjoyed it.